What's going on, everybody? Back for a little bit of a debrief from Zach's Tuesdays, spending time out and about, his role as Chief Clinical Officer, some of the conversations that he's having, some of the topics that are popping up, and we just want to make sure that we are continuing to create an environment and opportunities for everybody to benefit from them. So today in this video, we're going to talk about FAI, Femoral Acetabular Impingement. I think a lot of times when people are coming into the office, they're complaining of a pinchy hip. Oftentimes that could be related to getting into a deep squat or anything involving their knee coming up towards their chest. On an initial evaluation, what are some considerations? What are some things that maybe you're going through from a testing standpoint? And then how are you approaching that initial session with them, regardless of whether or not it's manual therapy or some kind of intervention that is more like medical exercise and home program focused?
So the biggest thing that I've found with FAI, one of the biggest delineating factors in your approach is this person a direct access or are they coming from an orthopedic? And the reason why I say that is FAI, it is a clear-cut diagnosis, but it is one that I would say over the last 10 years has become much more prevalent in the field and much more recognized. And there's still only a handful of hip orthopedics that I would say, I don't say feel comfortable, but perform a lot of FAI type procedures that aren't just under the umbrella of a labrum pair or another hip condition. So if you are going down the FAI route as a direct access clinician, from a diagnostic standpoint, we need to figure out, is this exclusively FAI? Is there presence of a labral tear? Are there other things that can mimic some of these FAI type symptoms when we talk about a pinchy hip with flexion, adduction, internal rotation? What are the age and demographic of a patient? Does it make sense for FAI, or is this more of just an arthritic hip if we're talking about an older population as well? But the easiest way for me to think about FAI is we have increased friction within the hip when we get into certain positions. Those positions typically being flexion, adduction, and internal rotation. And why are we getting that friction or that excessive contact? Is it exclusively anatomical, where it's either a cam or a pincer lesion, or is it because they're putting themselves into extreme positions that the normal population wouldn't find themselves in? So I think about some of your maybe your weightlifting athletes that are just constantly in a deep squat position, or maybe an athletic position like a catcher, or they're a gymnast or a swimmer where they have high repetition of these extreme positions. The second thing we need to ask ourselves is, do they have an inability to get into that position because of a mobility standpoint or an anatomical influence, or do they have an inability to control the position? And this is where I put like your swimmers and your gymnasts, that I'd be hard pressed to find anybody in either one of those sports that excels that has a true mobility deficit. And I would say they fall under the category of they can probably effortlessly get into and out of those positions, but maybe they don't have the strength or the stability or just the awareness as to how to control them. So when I'm looking at eval, things that I want to look at is this somebody that's fall more into the mobility bucket or the stability bucket in regards to provocating symptom profile with them. The other thing that I really like to figure out is just getting a grasp on the situation. If they have been referred from an orthopedic with FAI, what has been communicated to them in regards to expectations? Is this something that has been communicated to them as being a very mild issue, and it's almost like more of an annoyance or a nuisance that may kind of come and go throughout their athletic career, throughout their life, and they just need to recognize when and how it may come on and how to best manage it or limit the likelihood of it coming on? Or is it the complete opposite end of the spectrum where it's been communicated, we're going to try PT for a set amount of time and then entertain surgical intervention if that doesn't work? And I think what's been communicated to them is helpful to know as a PT on your initial eval. One, so that you're not contradicting what another individual is saying, or so that you can be a little bit more tactful as to how you approach things, either from a diagnostic or a prognostic standpoint, or more importantly, just when is our exit strategy? If we're not getting the results that we intended to get, when do we tap out, when do we refer, or when do we send them back to the orthopedic asking for what's the next and most logical step?
And then when it comes to, you've gone through differential diagnosis, you've considered, whether or not they had a referral. When it comes to the intervention side, are there any things that you're thinking of early on that maybe are, great places to start, a great catch-all that benefits a lot of this particular, patient subtype?
Yeah, so the symptomology and just how symptomatic they are on day one is going to influence how much do we go into the pain management, self-care, manual route versus how much do we go into some of our interventions that are geared more towards optimizing mobility and strength. So if you have somebody that's coming in and they're highly symptomatic and they're highly irritable, that's going to be somebody that you're going to be talking about identifying provocating activities and how to modify or avoid or limit the scenarios they're finding themselves in. You might be doing some manual intervention, most likely either like proximal quad, TFL, adductors, maybe some in the lateral gluteal area. And then you're also teaching some sort of self-care as to how they could mimic that on their own, whether through foam rolling or other techniques that way. And then mobility, I'm hard-pressed to find somebody who comes in with FAI that I don't find myself giving them some sort of quad or hip flexor stretch, whether it's a kneeling quad stretch or something in a staggered but front foot elevated position. And I usually communicate that as to we have several muscles and tendons in that area that can mimic or at least just overlap with the location of where you feel pain with FAI. So if we can introduce a stretch, we can at least tease out, is what we're constantly feeling more muscle and tendon related versus that true intra-articular discomfort that we're feeling. So it's good for body awareness, and it's also good for helping just with some of that mobility deficits that they may have as well. I like to clear up more of our sagittal plane deficits before going into a lot of frontal and transverse, but an adductor rock or something adductor oriented would be beneficial. And then I also like to give them something posterior in nature. So whether it's a posterior hip stretch for glute or some of the deeper rotators, or if you're just going straight posterior chain with the more general hamstring or toe touch progression as well.
Yeah, no, when I think about pinchy hip, I think oftentimes about like some of the stuff that works sometimes, like for pinchy ankle, pinchy shoulder, you're focusing on, increasing those movement options in other planes. You mentioned early on going after sagittal, and then jumping into frontal plane and transverse plane. So for me, I'm thinking adductors, I'm thinking external rotators, especially for that weightlifting population where they're potentially only doing a lot of sagittal plane stretching to begin with. And then, a big thing that I think for this population type is, you might get into some stability work, especially for your gymnast population where, they do everything really, really fast and they don't really have a lot of opportunities to kind of slow down. So I'm thinking of things like single leg balance reach or a hip airplane. Are there any other considerations you would give to the people that say have this very high seesaw, right? They have a lot of range of motion. There is a lot of freedom. They're rapidly going through it on a regular basis, but maybe don't get the opportunity to do things like an isometric or something involving a little bit more focus on time under tension.
Yeah, I think you hit the nail on the head. If they have you always reference kind of that big seesaw where they have very long levers or they have a lot of motion to go through, they have a lot of momentum to control, you constrain the seesaw. So you either put them in an environment where they're more isometric, they're more static in nature, you're increasing the amount of time under tension. So with this is where you're thinking about different either quadruped, high plank, low plank positions. With those, just being mindful of, we're trying to probably put them into like an anti-extension position, because in order to counteract that, they're going to need some degree of anterior core, so a lot of rectus engagement. And you're also going to be loading hip flexors that way as well. So I think you find pretty good success putting them into some of those anterior core isometric positions, or you're putting them into potentially more of an isotonic exercise where you're just decreasing the amount of range of motion they're going through. Or if you are having them with a relatively regular range of motion with the activity, you're providing some sort of definitive tempo at which they should be going at. Because a lot of your individuals that are more of your stability needs because they have great mobility, they're very good at utilizing momentum or the stretch shortening cycle with activities, or they do activities that already emphasize that so much that from a program design standpoint, they're probably going to get more bang for their buck by doing some of these more intentional, constrained strength activities.